Oh, that's okay.
Yeah. And for chapter, I think like 4 or 3, if I'm not mistaken, you haven't asked for.
So I need 5 through 9 from you.
It was 5.
Yep.
So for 5, I got a 95. Got one wrong.
Okay.
And then for 8 and 9.
I need 6. Yes. I need 6, 7, 8, and 9.
For 6, I got a 90. For 7, I got a 95. For 8, I got a 95. And then for 9, I got a 91.
Thank you. Very good. Uni?
I'm still working on it.
That's fine. All right. Any questions before we move on? Any questions? No questions? Everybody good? Okay, good. Very good. Okay. So at the end of the last class, I told you guys about a practice test on page 192. Did anyone get a chance to take the test over the weekend? Okay. How'd you do? Well, very good. Very good.
I've been doing the online one.
The online one? Okay.
Page 95.
Okay. Page 92. Or I'm sorry, 192. Sorry about that. 192. So it might be 191 now that I think about it. Yeah, 191. Sorry, I've got a headache. It's all on this side of my head today. It hurts. Okay. If you did not get a chance to take the practice test, try to do so before Wednesday's class. And the reason is, if you've got any questions on that practice test, I need you to be able to bring them to me while we're still in class, because Wednesday is our graduation day. If you missed 5 or fewer on our practice test in the book, you're ready for the written test. If you miss more than 5 on our practice test in the book, you need to see me, because I've got to look at the questions to figure out what area you're deficient in, and then kind of help you overcome that deficiency to give you the best opportunity for success. We also have the free ebook for you. It's 4YourCNA.com/ebook. And that will help you on the written test as well. I wrote that specifically for the written test. Okay. All right. Only one class left, guys. Have you registered for the test? If you have not registered for the test, you need to make that a priority, because remember, the whole process takes 3 to 4 weeks. If you haven't registered for the test yet, that means that, by the time you get around to registering, it's going to be about a month, 3 weeks to a month since you were in class. And that's a lot of time for what I've trained you to do to kind of go away because you're not using it. So if you have not registered for the test, you need to make absolutely sure that you're practicing while you're waiting for that test date. It's going to be a very important component of this. Okay. You need the background screening. Yeah, and then register for the test. Now, I actually, I am partnered now with a company called CaresLink, and they do a whole bunch of stuff, but they have like an online, it's kind of like LinkedIn for healthcare. That's the best way to describe it. It has job search capabilities right in the platform. It has education, so our CNA programs right in that platform. And I've been building that out for the last month for CaresLink. So as part of that build out, I actually went on to the Board of Nursing, and it's been a couple weeks since I've been on the Board of Nursing, and they've completely redone the website. It looks fabulous, but they now have this FAQ up at the top. So I clicked on the FAQs, and there's a whole section there for CNA. So I went through all of the questions, the frequently asked questions for CNA on the Board of Nursing website. And there was one thing that really stood out to me in these questions. The question basically said, and I wish I'd taken a screenshot of it, but the question basically said, if I already have a level 2 background check, do I still have to go get another one? And the answer surprised me. The answer said that you are required to submit a new level 2 background check in order to test. So that means that everybody needs a new level 2 background check. So it really simplifies instruction. You know, everybody has to go get one now, period. It doesn't matter whether you've got one or not. But it was very interesting to me because that was not the rule previously. So if you've not done your background check, you need to do that before you apply for the test. If you've already applied, when you get that email back from Prometric, there's a line that says FBI background status. If that line says record not found, it means that you don't have one for them to locate. If it says record found, then you're okay. But moving forward, I'm going to be telling students, go get a new level 2 background check because apparently that's what the Board of Nursing is requiring. Good? Good. Game shows tomorrow. I wrote all the questions for it yesterday. And the questions that this game show is going to focus on are psychosocial needs. These are the kind of the harder questions to answer on the state exam because they're all behavioral based. They're all communication. Like, what are you going to say when? What are you going to do when a patient doesn't want something done or expresses sadness because they're in a facility, or it's all psychosocial. And that's a big part of what we do. In this class, we really focus a lot on the skills, how to do a partial bed bath or how to do things. I've talked a little bit about the psychosocial all the way through. Make sure that you're closing the privacy curtain. We have conversations. Tell the patient what you're doing. We've talked a little bit about it. But along the way in your career, you're going to have a whole lot more conversations with patients than what we've done in this class. And you kind of need to know, how do you talk to people that you don't know? Young people tend to have a problem with this because you've been told all your life, stranger danger, talk to people you don't know. And now all of a sudden you're in a career where you have to talk to people that you don't know. And how do you do that? What's safe to say? What do I have to stay away from? How do I respond to these hard questions? And the answer to that, it's actually way more important than you think, because if you shut your patients down, if they don't feel that they're cared about, they probably aren't going to let you do the physical care. So tomorrow's game show is really going to kind of focus on that topic. And it's 15 questions. So if you have a chance, join us live at 11. Otherwise, catch the replay. But these are all questions that you might find on the state exam on this topic. Nope. Jake, where is Julie's QR code? Okay. So Jake's going to pass this around. This is the QR code for Julie's CPR class. I keep forgetting to do this. Julie this is her room. We use it. We rent it from her. She does CPR. She has a special rate specifically for our students. If you use the QR code, just, open up your camera, point, it'll give you her calendar and you can register for any of her CPR classes at a discount. You have to use that code for the discount, or, that site for the discount. So take a picture of it, bookmark it, whatever. You don't need CPR for this class. You don't need CPR for the test, although you may see some written test questions on CPR processes. But you're not required to demonstrate CPR. But you will need it to work. Almost every workplace requires that you are CPR certified. It's a one-day class. You get everything done in that day. Super quick, super easy. And Julie really makes it fun. She gets to have a whole lot more fun in her class because, her patients are already dead. You can't really go wrong. It doesn't get any worse than that. So whatever you do is an improvement, right? She gets to have a whole lot more fun. We're dealing with live people, so I've got to be a little more serious about it because, live people, we can make it worse. So if you get a chance, at least take a picture of that so that you have it moving forward. And I keep forgetting to give that to you. Workplace personality quiz, you should start thinking now about, where do I want to work? Am I a hospital type of CNA, or am I more of a rehab type of CNA? Would I rather do mental health or pediatrics? Do I thrive on routine? Well, assisted living or nursing homes might be your thing. Do I not really like people too much? Well, walk-in clinics might be a better option for you, because those encounters are very short. You don't have to develop relationships, you know? So you kind of have to figure out where you belong in healthcare, because all of those are very different types of CNA work. And I have a quiz to help you figure this out. So it's this 4YourCNA.com/your-ideal-workplace. So you can go here and figure that out. I do encourage you to take this before Wednesday's class. It's free. There's no cost. It takes 5 minutes of your time. It'll give you a lot of insight into your particular needs. This took me 2 years to develop. There's a ton of psychology in here. I tested it on several thousand current healthcare workers, and it's scary accurate. It's very accurate. So this is a really good resource for you, and it's completely free. So take advantage of that before you come to class on Wednesday, because we're going to talk about workplaces on Wednesday. And it's helpful if you kind of know the direction you need to be looking in. All right. So we're not doing a review. Remember, I said class 6 was our last review. So no review today. We're going to jump straight into skills. I'm going to show you the last 3 skills that we have to learn. And there's not a whole lot of new stuff to go over here. There's no principles. You already know all of them. We're going to learn how to apply those principles to the skills that we're doing. Today is all about toileting. We're going to learn how to help somebody with a bedpan. We're going to learn how to clean a catheter, and we're going to learn how to empty the catheter bag. Now, I do have to talk to you a little bit about infection control, because when we're working with catheters and drainage bags, the risk of infection is super high, and that can affect our patients in a very negative way. So we're going to talk a little bit about infection control. We're also going to talk about toileting methods. So there's lots of different ways that patients can take care of their toileting needs in a clinical setting. Outside of a clinical setting, we all have one. We go to the bathroom. So we really don't think about that there are options available. So we're going to talk a little bit about that, and how the nurses are going to be the ones that dictate how the patient goes, and we can't change that. So we're going to talk a little bit about that as well. I do have to go over catheters and how they work with you, to try to take some of that mystery away from it, to reduce your fear around catheters. Once you see what they are and how they work, it's like, oh, that's it. But right now, when I say catheters, you're kind of like, oh, catheters. So I need to get you over that fear part of working with a catheter. So we're going to go over those. You should have about roughly 2 hours of practice time in class today. So lots of practice time built into today. So let's get into it. If you go to page 147, this is our short version of the skill. If you look down the side here, you can see all the principles involved. They're all going to be spelled out for us here on the page. This is our test-specific information. So somebody with your level of experience should take about 10 minutes to do this. It's going to be done on a live testing student. That means one of you guys may find yourself on a bedpan for the test, but you're going to stay fully clothed. You're not actually going to use the bedpan, but somebody might be putting it under you and taking it away. So the way that we do this skill is you stay fully clothed, and they put a hospital gown on over your clothing. And then the care plan is written in a way that nobody's going to be anywhere near your personal area. Okay. So we're going to look at the care plan in just a second, but remember that you might be a patient for this. This is the short version of the skill. Once you've done it once or twice, you can probably just go to this to remember the important points. All right. So on page 148 at the top of the screen, you can see our care plan. It says the resident has requested a bedpan. The resident is not wearing undergarments. So let's stop there for a second. For the test, a patient for this, you are going to stay fully clothed. Our care plan says you're not wearing undergarments, so nobody tries to take your clothes off. If anybody during the test tries to take your clothes off, the evaluator is going to stop them and say, please refer to the care plan. They're not wearing undergarments. You don't have to take anything off. It also says that the patient is able to wipe themselves. Now, that won't be the case in every single situation you find yourself in with a bedpan, but that is the case with this specific patient. So nobody should be in your private area for this skill. Now, in a clinical setting, you may have to help somebody get cleaned up after using a bedpan, and that's because we have to think about anatomy. So bedpans are always in the bottom drawer here. This is a bedpan. Don't touch a bedpan without gloves. I'm just going to demonstrate this really quickly because remember, we just rinse, dry, and store. We don't disinfect. So you have to have gloves on to touch this. All right. So this is the seat part of the denture. It's where the butt goes, right? They're going to sit on this. Imagine sitting on, no, that's uncomfortable. We're going to sit here. So this part goes under the butt. That means if I kind of put this here, okay, and we have a patient on it, their undercarriage is right here. There's only about this much space between their undercarriage and the bottom of the bedpan. That's it. It's really hard to get in there and wipe. There's no room. Does that make sense? So when your patient is using a bedpan in a clinical setting, you're probably going to have to help them get cleaned up, but not for this patient. Good? Does that make sense? Good? All right. It also tells us the resident is able to move as directed. So the patient can lift up their hips, they can roll, they can do whatever it is that you need them to do to make this skill possible. There's two ways you can do this. You can ask the patient to lift their hips, best scenario. They can lift their hips, we just slide the stuff under them. It's easy peasy. But if they can't lift their hips for whatever reason, they're too heavy, they just had surgery, they had a motor vehicle accident where their seatbelt really did a number on their pelvis, they can't lift. In that case, we turn them on their side, put the bedpan up against their butt like this, and then roll them back onto the bedpan. To take it out, we're going to hold the bedpan flat while they roll off of it. If the bedpan is full, you don't want it like this. You got to hold it flat for them to roll off of it. Good? Good? Okay. All right. So for the test, we're going to ask our patient to lift their hips because it's the easiest way. And our care plan said that they're able to move as directed. So make it easy on yourselves. Just ask them to lift. Let's talk a little bit about toileting methods, though. So when a patient comes into a facility, remember that nurse has to do that whole head-to-toe assessment? We're looking for real problems and potential problems. Well, believe it or not, toileting is like really near the top of the list because I know that sometime in my patient's stay here, no matter how short it is, they're going to have to go to the bathroom. It's just inevitable. Even short stays, an hour or two, people may have to use the bathroom because of that whole stress reaction. So this has got to be pretty high on my assessment list. I got to figure out, okay, my patient's probably going to have to go. How are they going to go? So best case scenario, in a perfect world, they're going to take care of all of that themselves. I am not involved at all. They get up, they go to the bathroom when they need to go, they take care of their own cleaning, no help from anybody, just like you. That's perfect world scenario. That's what I want. I don't want to be involved in their cleaning. But if they were able-bodied, where would they be? Home. They wouldn't be here. So chances are that may not work for us. But if they can, then they're continent, they go to the bathroom, they take care of all their own situation. We call that bathroom privileges. So your care plan under toileting would be bathroom privileges. That means they get up, they go, we're not involved. That's ideal. We want that. Now, the next step down from that, if they can't do that all by themselves and they need a little bit of help, but they can still get to the bathroom, you know, either with help or they need some help while they're in the bathroom or just the whole process. They need help somewhere in there. We're going to have bathroom with assist. That means whatever they need, help them out. They might need some help getting there. They might need some help sitting down. They might need some help standing up. They might need some help cleaning up. They might need some help getting back to the bed. I don't know where their deficiency is. Just help them with whatever they need. That's bathroom with assist. Good? Make sense? Okay. Now, if that's perfect world, that's ideal. Patients are used to going to the bathroom, we want to send them there. But some patients aren't going to make it all the way to the bathroom. They're just not. In that case, for those patients, we're going to need to bring the bathroom to them. And for that, we use something called a bedside commode. It looks like a toilet. It functions similar to a toilet, has a toilet seat. But instead of a bowl that gets flushed, it's a pan that they urinate or defecate in, and then we clean the pan in the toilet. Okay, so these are good because you can bring them right to the side of the bed. That way the patient doesn't have to go anywhere. They just out of bed on the bedside commode. Now, this could be independently, right? As long as they have a toilet there by their bed, they can take care of it themselves. They don't need us. Or it might be bedside commode with assist. Means we help them with whatever they need help with. Make sense? Good? Okay. So that's ideal. So is the patient continent? Well, remember we learned last class, if they're incontinent, we just do pericare every 2 hours around the clock. You guys remember that? Okay, so if they're incontinent, we just do pericare. We don't have to worry about it. It's just pericare. No other decisions. If they're continent, bathrooms first, bedside commode second. Now, if they're continent and these two options won't work for us, now we got to make some decisions. The first thing I'm going to look at as a nurse that's doing this assessment is, do I need a catheter? Now, the emphasis is on need, not convenience. Need. Do I need a catheter? And what I mean by that is, will the pee not come out any other way? Or if the pee comes out, will it interfere with something else? Okay. So catheter has to be need-based. So let me give you a couple examples. Let's say a patient had prostate surgery. Older gentleman, we went in and took out his prostate, but along the way, we accidentally cut the nerves that control the valve at the bottom of the bladder. Remember that valve? How important that is? Well, if we accidentally cut those nerves, and they're super small, they're like the width of one single hair. They're tiny nerves. And if we accidentally cut one of those nerves without realizing it, now that valve will never open again. It won't open. What do you think happens if we have a valve at the bottom of the bladder that never opens? Yeah, the pee isn't coming out. It's going to cause, all that pee to get backed up. And now we're going to end up with excess fluid in the kidneys. They're not going to be able to filter the blood. Now our blood is all trashy, and that backs up into the liver because the liver tries to take over, and the liver can't handle all of the trash. So we end up with a lot of electrolyte imbalances just because our patient can't pee. And now the patient's in the ICU, and we probably got them on all kinds of machines to keep them alive just because they can't pee. That's a problem, isn't it? So in that case, I would need a catheter to hold that valve open so that the urine comes out. that's a need for a catheter. Now let's talk about childbirth. A lot of people, when they give birth now, get epidurals because we don't want to feel the contractions. They hurt. So we get epidurals. So that epidural is going to numb everything from the mid-chest down. Well, if you're numb from the mid-chest down, you aren't walking to the bathroom. Your feet are in a whole nother zip code at that point. They are not cooperating. They're not even on the same floor. So you can't get up and go to the bathroom. And because you're numb from the waist down or from the mid-chest down, you can't control that valve at the bottom of your bladder. So if the valve isn't working, what do we need? A catheter. So when you get an epidural, you would need a catheter. But sometimes in childbirth, even without an epidural, we put a catheter in. And that's because when you push baby out, you push everything out. Whatever's inside is coming out. It's not selective pushing. So if you have urine in your bladder and you're pushing baby out, you know what's coming out? Urine and baby. So sometimes we'll put a catheter in during childbirth because it's not convenient to have urine coming out with baby. We also use catheters during surgery because when we put you to sleep, we put all of you to sleep, including that valve at the bottom of the bladder. And we don't want you peeing on our sterile field during surgery. Make sense? So we have to have a reason to use a catheter. It's not just a go-to, first stop. We got to have a reason to put this thing in. Now, if I have no reason to put a catheter in, now I'm down to the very last choice, a bedpan. Do you see how much I had to go through to get to bedpan? That was a whole lot of work just to get to bedpan. This is not our first choice. It's actually my last resort. That's because there's a psychological component to this. You have been trained since you were about this tall. Don't pee in the bed. Don't pee in the bed. Don't pee in the bed. And certainly don't poop in the bed. Absolutely not. Now, remember those lessons that we learn early in life tend to stick with us long term? Remember that? They're foundational lessons. Well, if you're laying in a bed and I put a plastic pan under your butt, your brain is still saying, excuse me, we're in a bed. We're in a bed. And the rule is don't pee in a bed. And I'm in a bed. I can't pee. And this happens when we use bedpans quite often. You'll put a bedpan under somebody. They'll go, oh my God, I got to go. You put a bedpan under them and they're like, I can't go. It's very common. And that's because of that psychological restriction. Your brain is saying, stop, not the right place or time. Now, there's a couple things we can do to help our patients out here. The first, privacy. Privacy is so important with this skill. Now, of course, we're going to use the curtain. That's a no-brainer. We'll use a privacy blanket if you want to, or the sheet. We're going to keep them covered. That's a no-brainer. But there's some other things that we might want to think about because people are only separated from their neighbors by a thin curtain. This isn't going to do a whole lot for privacy. And your patient is probably pretty aware of the sounds that they are making. Think about that for a second. They are also probably aware of the odors that are being produced. And they know that 4 feet away, separated by a curtain, is another human that they have to live with while they're here. Do you think that's a comfortable situation? No. So a lot of times, unconsciously, your patient will kind of clench up because they're not comfortable with that. So if at all possible, privacy. If we can get that roommate out of the room, take them on a walk, to an activity, take them to the bathroom if they can go, get them out of the area for privacy, you have better results. Make sense? You can also do things like turning the water on. The sound of running water can help with the urinary letdown reflex. You can also submerge the hands in warm water, and that helps with the urinary letdown reflex as well. So if your patient is using a bedpan, having a hard time, we can use these little tricks to help them go. But you may have to just, okay, we'll try again in a little bit. Let me know when you're ready and we'll try again. We're going to use a lot of patience with this. It may take 3 or 4 times for your patient to be on a bedpan to finally go. We may have 3 or 4 unproductive attempts. And that's okay. We're going to be patient with this person. We're not going to do, really, again, I just did this 10 minutes ago and you weren't able to go. What do you want me to do? Right? That's not the attitude we want to have. We want to be patient and cooperative and accommodating. Does that make sense? Good. All right. So remember, bedpan is the last resort. If this is on the care plan, the nurse has already gone through all the other options and discarded them. Now, I bring that up because there was recently a situation where a CNA made a decision and altered the care plan and got in trouble for it. The care plan indicated that the patient was supposed to use a bedpan. And the CNA put the bedpan under the patient. They weren't able to go. And the CNA said, all right, fine. I'll just get you out of bed and take you to the bathroom. Along the way, the patient fell, hit their head, ended up with a subdermal hematoma that had to, it was a woman, but she had to have a flap of her skull removed for the swelling to be managed. All because a CNA made the decision that, that care plan doesn't work for me. That CNA got in trouble. Not because the patient fell. The CNA did not get in trouble because the patient fell. The CNA got in trouble for failing to follow the care plan. The result of that was the patient fell. Do you guys see the difference there? CNAs often will fixate on things that make it safe for the patient. I don't want to walk that patient. It's not safe. I don't want to get in trouble if the patient falls. It all comes back on them. I don't want to get in trouble if the patient falls. So it's not about the patient, is it? It's about you being in trouble if the patient falls. That's the mindset out there. And you're going to hear this a lot when you go to work. I don't want to get in trouble if that patient falls. I don't think that patient is safe to walk. I don't think. Are we allowed to think? If you have that thought process, who should you bring it to? The nurse. Don't make decisions on behalf of the nurse. Okay? Does that make sense? You will get in trouble for failing to follow the care plan. That's where your trouble will come in. Good? Questions on this? Do you guys understand that bedpan is a last resort? If the patient can't use a bedpan, the nurse has got to figure out another alternative. All right. So we have this bedpan that's right underneath the patient's bottom. Only this much space between the undercarriage and the bottom of the bedpan. Bottom of the bedpan is flat and plastic. Pee is under pressure. So when that pee comes out under pressure, it's going to hit the bottom of that bedpan. You're going to get splashback. Now, the undercarriage is only this far from the splashback. So whatever is going into that bedpan will get on the patient's undercarriage. No way around it. This is not neat. It's not clean. So we have to concern ourselves with how to keep whatever's going into the bedpan in the bedpan and keep it from going onto the sheets. And one of the ways that we're going to do that is by putting a chucks underneath the patient before I put the bedpan in place. That way, if anything should come out, it's not going to get on the patient's sheets. That chucks will absorb it. Remember, chucks are always put on with the absorbent side facing up, not the plastic side. Okay, good. All right, we are going to position the bedpan. Remember, the wider end of the bedpan goes under the patient's butt. And we're going to put the head of the bed up. Now, let me explain to you why this is the most important step of bedpan. The most important step. So if I have a bedpan, let's pretend that's a bedpan. And I have a patient on my bed. So here's my bed, here's my patient, and here's my bedpan. I put this bedpan underneath the patient. What does it do to their middle? Yeah, it humps it up. It makes it higher, right? How many of you ladies can pee uphill? Probably not going to be very successful, are you? And you certainly can't have a bowel movement uphill. So when you put a patient on a bedpan, this is not a position that allows them to go. We need to get them into a normal elimination position, which is sitting. So that means for this skill, the most important step is to put the head of the bed up. They can't go like that. And if they do go, if they're able to push that pee out, it's going to go right up their back and into their hair. And I don't know about you, but that's pretty high on my gross meter. Make sense? So the most important step here is to put the head of the bed up after the bedpan's in place. We'll give them their call light, their toilet paper, give them some privacy. And then when they let us know they're done, we're going to come back in. But we can't get that bedpan out from under them if they're sitting on it. Their whole body weight is pressing down on that bedpan. It's not going to come out. So in order to get that bedpan out, we need to put the head of the bed back down. And then remove the bedpan and the chucks it's laying on from underneath the patient. You guys understand why that's the most important step? Now, this bed controller, it's not clean. We know it's not clean, but we have to think, we just had gloves on to put that chucks and bedpan under our patient. So now we have butt juice covered gloves. Do you want to use those butt juice gloves on that bed controller? No. So we put the head of the bed up, we take our gloves off. We put the bedpan and chucks under the patient, we take our gloves off, and we put the head of the bed up. Good? For the test, you have no other patients. You have nowhere to go. You're kind of stuck. It's just one place, one patient, one environment. So you're just going to step on the other side of the curtain and wait. But in a clinical setting, they don't need the audience. Wash your hands, go away. Go take care of somebody else. When the call light goes off and they say they're done, then you can come back in, wash your hands, and finish up. But for the test, we have nowhere to go. So we're just going to step on the other side of the curtain. And because we didn't leave that patient environment, we don't have to wash our hands yet. So we're just going to step on the other side of the curtain and wait. Now, they need their call light and their toilet paper before we step on the other side of the curtain. That way we will be notified when they're done. And remember, our care plan says they're able to wipe themselves, so they need some toilet paper to be able to do so. So call light, toilet paper, you step aside, wait for them to say they're done. And when they're done, we're going to come in and put the head of the bed back down. Before we get that bedpan and chucks out from under them, though, there's urine there. What do we need? What do we need? Gloves. So we're going to put our gloves on, get the bedpan and chucks out from under the patient, and I want to wrap that chucks around the bedpan. No one needs to see what's in that bedpan. That's a privacy issue. But it's also an infection control issue, because if I'm carrying an open bedpan through an area and I trip on my shoelace, do you know what's going to happen? I'm going to go head first into that body fluid. I got a lot of holes here. That's a lot of exposure to pathogens, but it's also really, really gross. So wrap your chucks around your bedpan while you take it to the bathroom area. Once we dump the bedpan into the toilet, we'll rinse the bedpan, dump the rinse water in the toilet, dry it, and store it. Then we can take our gloves off. Your patient wiped themselves, so we're going to give them a hand wipe. They got to clean their hands. They just used the bathroom. So I'll give them a hand wipe. And then I can take the privacy blanket away if I used one. You don't have to use a privacy blanket for this skill. And then I'll do my closing. Now, I want to talk to you a little bit about something called a bedpan cleaner. We talked a little bit about this earlier in the program, but here's a picture of it. It looks like a little shower head, you know, with like just a small round thing at the top. If you pivot this forward over the toilet, it'll start spraying into the toilet, and it allows you to clean the bedpan right over the toilet instead of using the sink. It's a great invention. It's awesome. The problem is that not all facilities have this. If you do have a bedpan cleaner, you have to dress for the job, because we might get some splashing. Remember we talked about wearing a gown for splashing? So you would want a gown, and you'd want to cover all the holes of your face so that any splashing isn't going to get into any of those holes. Good? Make sense? So that's what a bedpan cleaner looks like. Bedpan has to be positioned properly under the patient for them to use it. Now, problem is we're going to put the head of the bed up. So we put the bedpan under the middle of the patient, but that's the part that's going to bend when we put the head of the bed up. So that bedpan is going to shift forward or back a little bit, and you're going to have to kind of accommodate for that. You can tell the patient to adjust the bedpan after you get the head of the bed up if they need to. So any questions on that skill? No? All right, Jacob, can you play the bedpan skill for me? What's that? Here on this one, over here, make sure it's Fire TV. Hit test. And make sure we're not muted over here. The TV.
Hello.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm well. How are you?
Fantastic. I understand you need a bedpan. Can I help you with that?
Yes, please.
Okay, I'm going to close. Technical difficulties, guys. We'll be right with you. Oh, hold on. There's one more thing to check. Let me sit for a second.
Output's correct. It's playing.
Let me just
TV
try
audio.
this. All right, guys, we're going to take a quick break. We're having some technical difficulties. We'll be right back. I'm going to take the stream down and bring it back up. So just
Hi, Mr.
we'll be back
Jones.
with
My
you in
name
a
is
minute.
Patty. I'm your CNA today. How are you?
I'm well. How are you?
Fantastic. I understand you need a bedpan. Can I help you with that?
Yes, please.
Okay, I'm going to close your curtain, wash my hands, get my supplies, and I'll be right back. After I've washed my hands, I'm going to get my supplies. I'll start with a barrier, unfolding it with the absorbent side facing up, and this is going to give me a clean place to put my clean supplies. And we're going to start with the chucks. And then I'll move over here to the patient environment. I need Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm well. How are you?
Fantastic. I understand you need a bedpan. Can I help you with that?
Yes, please.
Okay, I'm going to close your curtain, wash my hands, get my supplies, and I'll be right back. After I've washed my hands, I'm going to get my supplies. I'll start with a barrier, unfolding it with the absorbent side facing up, and this is going to give me a clean place to put my clean supplies. And we're going to start with the chucks, and then I'll move over here to the patient environment. I need a set of gloves, a second set of gloves, hand wipes, and I'll need the bedpan, which will be in the bottom drawer. I'm going to open the drawer, but I'm not going to touch the bedpan until I put my gloves on. We'll go ahead and put the gloves on. I'll take the barrier and prepare it by holding it up with the absorbent side facing me, and I'm going to roll it toward me. And we're going to set that aside. I'll get the bedpan and the toilet paper out of the drawer, and we'll put those on the bedside table. Now we're ready to start the skill. Okay, Mr. Jones, I'm going to ask you in just a moment to bend your knees and put your feet flat on the bed, and you're going to lift your hips up for me so I can unroll this chucks underneath you. This is going to protect your bedding while you use the bedpan. Okay? So I'm just going to loosen this sheet up a little bit so we've got some working room. I'll take my prepared chucks, and we're going to place it on the bed where we're going to unroll it under the patient. It needs to be under the middle of the patient where the bedpan is going to go to protect the sheets from becoming soiled. Mr. Jones, can you bend your knees? And I want you to lift your hips as high as you can go. Thank you. I'll unroll that chucks all the way to the other end. Okay, you can relax. There you go. Now we're going to put the bedpan under the patient. The wider end of the bedpan goes under the patient's buttocks. So this will be toward the foot of the bed. Mr. Jones, can you lift for me? Thank you. Go ahead and come down. Make sure that that's centered appropriately. All right. And now I can remove this set of gloves. We'll throw these gloves away, and I'm going to put the head of the bed up. Mr. Jones, I'll put the head of the bed up now. That bedpan may shift a little bit. Feel free to move it as you need to, and let me know when you're comfortable. And you can relax your legs. So you comfortable? Okay. Here's your toilet paper. Here's your call light. I'm just going to step on the other side of the curtain and let me know when you're done. Okay, Mr. Jones, are you done?
I am.
Very good. Let me lower the head of the bed. There we go. And I'm going to put my gloves on. All right, Mr. Jones, in just a moment, I'm going to ask you to bend your knees and lift your hips off of the bedpan, but wait until I tell you because I need to hold that bedpan flat.
Okay.
Okay? I'm just going to move this out of the way. I'll take a corner of the chucks. Go ahead and bend your knees. Don't lift yet. I'm going to take a corner of the chucks and hold the front of that bedpan down as he lifts. Go ahead and lift, and I'll pull the whole chucks and bedpan out. Relax. And we're going to take this to the bathroom for disposal. I'll bring the bedpan over to the patient bathroom area. We'll unwrap the chucks from around the bedpan and dispose of the chucks. And then we're going to dispose of the contents of the bedpan into the bedside commode. For testing, this is a simulation skill. There will not be anything in the bedpan, but we're still going to follow through with the simulation. We'll lift up both the seat and the lid. We're going to dispose of the contents of the bedpan into the bedside commode or toilet. And then we're going to rinse the bedpan. We want to put the rinse water into the commode as well. Now I'm going to set the bedpan down into the sink, disinfect it per facility policy, and then use a paper towel to pick it up. I'll take a paper towel to dry the inside. Throw that away. Another paper towel to dry the outside. Throw that away. And then one more for the drawer. Now that I've cleaned the bedpan, I'll get the toilet paper, place it in the bedpan, open the drawer with a paper towel, and then we're going to position this bedpan in the drawer and close the drawer with the paper towels. I'll then throw these paper towels away. We're going to remove the gloves and throw those away. I'll get a paper towel. Mr. Jones, I'm going to give you a hand wipe so you can wash your hands after using the bedpan. Go ahead and take a hand wipe. And then I'll collect that hand wipe after you're done with the paper towel.
Thank you.
This keeps me from touching the hand wipe. We'll throw this away. We're going to throw the barrier away. Clean our work environment. So I'll pull the sheet up, make sure that it looks good. And here's your call light, Mr. Jones. If you need anything at all, just press that red button and we'll be happy to come back and help you. I'm going to remove your bedside table and open your privacy curtain. Is there anything else I can get for you while I'm here?
No, thank you.
Are you comfortable?
Yes.
Would you like a magazine before I go?
No, thank you.
Okay, your bed is in the low position. Your environment is clean. I'm going to go wash my hands. After washing my hands, I'll review the care plan, think about my skill, make any corrections, and then tell the evaluator my skill is done. All right, any questions? Sorry about the technical problems. It does seem very bright. All right, so the next skill we're going to learn how to do is catheter care. So this is going to be on page 158 of your book. If you look down the side, you'll see all the principles involved. They're all spelled out for us here. Pretty much every principle except for shoe rules is going to be used. This is a variation of pericare. What we did for pericare, we're going to do again for catheter care. But we're also going to clean the catheter tubing. So nothing really to learn here other than how a catheter works. This is a mannequin skill. It's also a longer skill. They're going to give you somebody with your level of experience 15 minutes to get this done. The mannequin will be in the bed for this skill. So if you look at the top of page 159, you can see the care plan. It says provide catheter care with soap and water to a female resident with an indwelling urinary catheter. Clean the catheter tubing and perineal area only. So remember pericare, we cleaned both the front and the back? Well, that was because the patient was laying on that wet pad. That means that there was urine on their butt skin and we had to get that urine off because it's acidic. Well, with a catheter, that urine is not under the patient. It's in a bag. So for catheter care, we usually don't have to clean the backside, just the front side.
Here are some results.
This thing is wacky. Yeah. Okay. Crazy. But we do have to clean the catheter tubing where it exits the body. So pericare was done every 2 hours around the clock. Catheter care is usually done once a shift. So not as often, once a shift. All right. And remember, your care plan says catheter tubing and peri area only, so we're not cleaning the backside. All of your supplies are here at the bottom of the screen. This does take a lot of supplies. You will need to learn your supplies. Keep that in mind. So pericare, we changed the chucks. We cleaned from top to bottom down the front. Whatever we wash, we rinse. Whatever we rinse, we dry. And then we change the chucks again. You turn the patient over, clean the backside, change the chucks again. That was pericare. So catheter care is going to look very, very similar, right? We're going to put a chucks. They're not going to have one there. We're going to put a chucks under them. We'll clean the front, top to bottom. We'll clean the tubing away from the body, and then we'll take the chucks away. Good? So this is going to be done once a shift. We're going to clean the catheter and the skin around it. And we're also going to inspect the tubing, make sure that the bag isn't on the floor, the tubing isn't kinked, the tubing isn't coiled where somebody can get their feet all tangled up in it and pull it out. So we're looking at the whole system. This is what a catheter system looks like. You've got the catheter. This is the part that's inside the patient. You've got the catheter tubing that extends outside of the patient. And the catheter tubing is going to terminate in 2 ports. We'll talk about that in a minute. One of those ports is going to connect it to some sort of a drainage bag. So this is a closed system. One end is inside the patient, and there's no openings all the way to the bag, closed system. So that means that bacteria have virtually no chance of getting into that system as long as it's closed. But if it's opened, now we've got a possibility of bacterial intrusion. Make sense? Okay. So that's going to kind of drive what we have to learn, is that as long as the system is closed, it's good. But if it's open, there's a possibility of contamination. Well, as CNAs, we are going to open this system to empty the bag. That means that there's a possibility of contamination when that happens. So these are 2 separate pieces, and we're going to talk about that in just a second. Just remember that the catheter and the bag are 2 separate pieces that join together right here. And this is a real world example of how that looks. This is the catheter over here. This is the bag over here. They connect here, 2 separate pieces. As a CNA, you can be trained to separate this to change out the bag. You can be trained, but that's not part of your initial training. You would only be trained on this if it applied to your job. So as a CNA taking the exam, we do not separate these 2 pieces. You have to have additional training to do that. Okay, good? Good. All right, the catheter can stay in place up to 30 days. That's why they're 2 separate pieces. Once a nurse puts a catheter in, nurses put catheters in, CNAs don't. Once a nurse puts a catheter in, it's got to stay, or it can stay in place for up to 30 days. But that bag itself is going to be changed about once a week. So if the catheter can stay in for 30 days and the bag needs to be changed once a week, they have to be 2 separate pieces. Okay. All right, so what are CNAs responsible for here? Well, nurses put catheters in and nurses take catheters out. CNAs can be trained to take a catheter out if your job requires it, but nurses still put them in. Okay. CNAs are mainly responsible for keeping it clean and emptying the bag. That's what our main job is going to be. With additional training, you can learn how to change the bag or take the catheter out, but that's additional training down the road, not right now. All right. So here's our problem. Do you guys remember this chain of infection thing? This is our problem.
right? If we have a pathogen and that pathogen has a place to live somewhere in this system, that pathogen is hanging out somewhere in this system. We have to make sure that that system stays as pathogen free as possible. And that's because urine really is like the ideal environment for pathogens. Like every pathogen wants to find a bladder to get into. It's warm, it's dark, it's moist. There's an all-you-can-eat buffet, which are enzymes that the pathogens need to procreate. And there's an open bar. Those are proteins that make it even easier to procreate. So this is like every pathogen is trying to find a bladder to get into. It's like nirvana. It's like vacation land for them. So we need to understand that this is where they want to be, and we don't want to make it easier for them to get there. So if you remember the urinary system, when we learned it last week, we have some kidneys that filter blood, produce urine. That urine drips down tubes called ureters into the bladder. Little valve at the bottom of the bladder is closed, keeps the urine inside till you go to the bathroom, valve opens, urine comes out. 5th grade anatomy review. Well, when you have a catheter, system works exactly the same. Nothing has changed here. Kidneys still filter blood, produce urine. Urine still drips down the ureters into the bladder. Nothing has changed there. What we did was we used a catheter as a doorstop to hold that valve open and a tunnel to direct the urine out. That's all we're doing. We're holding that valve open with a catheter. And then the hole at the top of the catheter allows the urine to drain down inside. If you just held that valve open, you'd have an incontinent patient. That's not good for the skin. So we're going to hold the valve open and use a straw. That's all a catheter is a straw, flexible straw, to allow the urine to go in a directed manner into a collection device. Very first catheters we ever used way back when were glass. Yeah, they weren't very flexible. So if you used a catheter and put it in, that patient had to stay really still. Over time, they realized that it would be better if it was flexible. But back then, we didn't have the plastics and petroleum products we have now that make up flexible silicone or rubber or anything like that. So our methods have changed as technology has given us new materials to work with. So now catheters are very, very flexible. The tip of it is rounded to make insertion a little bit easier. The holes are on the sides, but it's still a straw. Still a straw. The urine will go in those holes and down the inside of the catheter. So this is what the catheter looks like. This is what it looks like when it's inserted by the nurse. You can see that there's a balloon on this one, and there really isn't on this one. So once the nurse gets this in place, they've got to inflate that balloon. This is a tube inside a tube situation. So they would take some sterile water once the catheter is inside the bladder, and they would put the sterile water in. And now I have a bubble that just sits on top of that valve and keeps the catheter from coming out. Now, if I pulled it really hard, it's going to come out. And that's what happens to patients when they tug on their catheters, or CNAs pull out more catheters than patients do. We'll talk about that in a minute. But you don't want to pull really hard on this. It's just a water balloon that's keeping it in place. For the catheter to come out, the nurse would take a syringe, pull the water out, so the bubble deflates, and then it just slides right out. That's all a catheter is. That's it. That's why it has 2 ports here. One is going to attach to the bag. The other one is how we insert and remove water to inflate that balloon to keep it in place. Good? Good. I'll pass this around in just a second. So this is what the whole system looks like as a closed system. The bubble is inside the bladder, sitting right on top of the valve, which is holding the valve open. The catheter comes out of the body. We have this connection to the bag, and then we have tubing that leads the urine into the bag. Closed system. One end inside the patient, one end out here. Closed system. but we're going to open that system. There's two different types of bags that I want you to be aware of. This is a bedside bag. That's what I have here. It's a big bag. It kind of hangs out on the side of the bed. Hangs out on the side of the bed and holds the urine. But if this patient is walking around the community, they don't want to carry a suitcase of urine along with them. That's just weird. You'd definitely stare if somebody was walking around Walmart with a bag full of urine, right? It's weird. Patients know that. So if somebody is out in the community, is mobile, we use a different kind of bag called a leg bag. Leg bag attaches to the inside of the thigh or the calf with some elastic bands that just holds it in place. That's all it does. Holds that leg bag in place. The tube is a little bit shorter. See how long this is? The leg bag tubes are going to be a little bit shorter because it doesn't have to stretch as far. Okay. So this is more discreet, bless you, for people that are in the community. These are also, side note, called stadium bags. Remember I said everything in healthcare has a couple of different names? Leg bags are also called stadium bags. Anybody care to guess why?
People use them to stay longer on the game.
Yeah, that's right. That is correct. Instead of having to miss a crucial play by your favorite team because you had to go to the bathroom, usually gentlemen will use an external catheter and a leg bag to collect their urine during the big games. These are your diehard fans, but that's why it is also called a stadium bag. Yeah, I am not that big of a sports fan, but interesting. All right. So the name of the game here for this whole system is infection control. Because if we allow bacteria into this system, that bacteria is going to multiply. Remember, urine is a good environment for bacteria. It's going to multiply. It's going to run out of room and start to climb. Now, as it climbs, it's getting fresh food, so it multiplies even faster, and it keeps climbing. Now, once it gets into the catheter itself, we've blocked out light. So we've got warm, dark, moist, fresh food, open bar. It's really going to ramp up. So by the time those pathogens get to the holes at the top of the catheter and can jump out into the bladder, it's not 1 or 2 bacteria. It's 1 or 2 trillion bacteria that quick. This is a patient that can go from I'm okay to I am really sick in 30 minutes because the bacterial invasion is so overwhelming and so fast. Because those bacteria were able to hide in the catheter the whole time and then invade all at once. So do you guys remember hearing in high school the Trojan horse? That's what a catheter is. The catheter is a Trojan horse that literally allows bad guys to hide inside and be taken directly into enemy territory. So we've got to be really, really careful here not to allow pathogens into that system because there's nothing in that system to prevent pathogen growth. There are no bodyguards. There's no bouncers inside this system, no white blood cells to kick out the bacteria. They're just going to be super happy and procreating like there's no tomorrow. Okay. So when we're working with patients with catheters, we really want to pay attention to signs of infection. Now, when we're young, those signs of infection are often urgency, like I feel like I really have to go to the bathroom. Frequency, like I'm in the bathroom every 10 minutes. Burning or pain on urination or inability to urinate. You won't get any of those signs with a catheter. So the signs that usually let us know, hey, I might be getting something, in my urinary tract system. I probably ought to take an antibiotic or something to get rid of it. We don't have any of those symptoms. So we need to be paying attention to changes in vital signs, changes in skin color or temperature, if they start to get flushed or warm, that's something we need to let the nurse know. So anything that's unusual when your patient has a catheter, no matter how minor it seems to you, has to be reported because it may be an indication of a system change in the patient. But the number one sign of a urinary tract infection in the elderly, with or without a catheter, doesn't matter, is sudden confusion. If your patient was fine yesterday, knew who they were and where they were, and today they're talking about, the kitty cats who came into the facility last night and kicked them out of bed, and, that's just not normal. You need to let the nurse know right away. Don't assume, oh my gosh, they got dementia overnight, because dementia doesn't work that way. Confusion that's sudden is not a sign of aging. Aging does not happen suddenly. Nothing that is sudden is normal. Make sense? Good? Okay. If you see on the written test anything that is sudden, a change that happened over a period of a very few days, hours, or minutes, it is not normal. What would we do with not normal? Report it to the nurse. So keep that in mind. You'll have 2 or 3 questions on the written test that deal specifically with that. If it's sudden, it gets reported. Okay, good? Make sense? All right. So there's 3 different entry points, 3 different places that pathogens can get into this system. We know pathogens in the system, bad idea, but there's 3 places that can happen. The first is when the catheter is put in. That's the nurse's problem. That's why this has to be done sterile technique. That's why CNAs don't put catheters in. You don't do sterile technique. Nurse's problem. This down here is our problem because we empty the bag. We're going to learn how to do that skill in just a minute. We empty the bag. So if we empty that bag and allow pathogens into the system, that's us. And that can kill our patient. Catheters kill about 2,500 people a year. Yeah, these are serious. This one is the one you have to be trained on. So remember, this is us. That's the nurse. This can be done by either, but you have to have additional training because, again, it's another place that pathogens can enter. Now, what makes this one a little more dangerous than this one is it's closer to the body. If we allow pathogens in down here, they got a long way to go. That's a lot of space for them to travel. If we let pathogens in here, that's really close to the bladder. That's only this far away to the bladder. That's not far for pathogens to travel. So this has a higher level of risk. We also have fresh food, warm urine. It didn't get down here and cool down yet. And all the enzymes and proteins that you could eat. So doing this is going to require additional training because higher level of risk. Good? Now, bags themselves need to be hanging on a non-moving part of the bed. That makes sense. You don't want to pull a catheter out when you put the head of the bed up. Non-moving part of the bed. But it also has to be off the floor because we don't want pathogens anywhere near the port. So not on the floor. Do not raise a catheter bag above the level of the patient's hips either. Recycled urine. That urine's going to fly right back into the bladder and take any pathogens that are along the way with it. Like a water slide, just whoo, right into the bladder. But also recycled urine, that's pretty gross. Urine really should be a one-way trip. It should not go back in. Make sense? So don't lift it up above the level of the patient's heads. Anybody watch any Discovery shows online? This one just, I scream at the TV way too often. You'll see people that are walking a patient down a hallway and they'll be holding the urine bag up like this. It's like, no. Don't allow that urine bag to be above the level of the patient's hips. Patients do pull catheters out. Absolutely. They're a foreign object, right? They don't belong. And this is not a really big catheter, but it's got to fit snug in the urethra. Because if it's not fitting snug, that's going to allow urine to leak around it. Now we're going to have leakiness. So it's got to fit snug. Well, that's going to make it uncomfortable because it's snug. So patients don't like catheters. They're uncomfortable. This shouldn't be painful. The patient says, ow, let the nurse know. That's not normal. But uncomfortable, that's kind of normal. Your patient will often say, I feel like I have to pee. Well, that's just because the only thing that's ever hit the top of the bladder has been pee. So if the top of this catheter is hitting the top of the bladder, because there's no urine in there, the bladder's very small right now. The top of the catheter is hitting the top of the bladder just thinks it's pee, and it rings a bell in the brain and says, hey, we probably need to go pee. So having the patient say, I feel like I need to pee when they have a catheter, very normal. The body does accommodate after about 12 hours. That sensation kind of goes away, but let the nurse know. Normal. Ow, not normal. Let the nurse know right away. The patient says this really hurts. We need to let the nurse know. But patients do pull catheters out. Absolutely. If you catch a patient tugging on a catheter or they start complaining about it, let the nurse know. I'm going to see if I've got any other options, because pulling a catheter out is no fun for anybody. Right? We've got this bubble that's this big coming out of a hole that's this big, where you're going to get tissue tearing. You're going to get some blood. You know, and then if the patient has to pee through that, can you imagine peeing through that tissue? It's going to burn. It's going to hurt. We don't want the patient to go through that. So no fun for anybody. So if the patient's tugging on the catheter, make sure you let the nurse know. We'll see if we can come up with another option. But what if the patient does pull it out? It happens. It happens. Yeah, you're going to see some blood. And the patient's probably going to say, oh, it hurts. Yeah, I would imagine so. You know, but they're not going to die. It's okay. It's okay. Don't hide it. For some reason, I don't know why, right now, there seems to be a predominance of CNAs that are hiding catheters that were pulled out. Like they'll throw them away and not tell anybody. They'll hide it till the next shift and let somebody else deal with it. It's just not, don't do that. Because as a nurse, I only have 45 minutes to figure this out. Any injury is going to cause swelling. This is not a place we want swelling to occur. If there's swelling, the pee may not be able to come out. Does that make sense? So if I've got to put another catheter in, I've got to do it within 45 minutes of this injury. Now, if you hit it and didn't tell me that the patient pulled the catheter out, and I find out 3 hours later, I have no options here. I am out of options because there's swelling there now. I can't do it. Now I've got to call the surgeon. We have to figure this out on a much higher level. So if a catheter comes out, don't hide it. Put it in a bag, an empty trash bag. At the bottom of every trash can are empty trash bags. Grab an empty trash bag, put the whole thing, the bag, the catheter, everything in that trash bag, put it in the patient bathroom and go find a nurse. Hey, catheter came out, it's in the bathroom for you to inspect. And the reason you want to do that is because as the nurse, I've got to look at that catheter and make sure that all of it came out. If I look at a catheter like this, that balloon should be inflated. If it's not inflated, I've got to check very, very closely and make sure there aren't any pieces missing. Because if there are pieces missing of this balloon that caused it to collapse, where do you think those pieces are? In the bladder. And we can't leave foreign objects in the patient. That's a problem. The only way for me to know is to inspect it. If you have thrown it away, I can't inspect it. Make sense? Now, all of that sounds horrible, but this is the real reason that most catheters get pulled out. It's not the patients, it's the CNAs. If this tubing is near the floor, your feet will get tangled up in it and you will pull it out. But there's other ways that CNAs pull catheters out of patients. When we transfer a patient out of bed and into a wheelchair, if that bag is on the other side of the bed and I didn't notice it, I'm going to pull that catheter right out as I transfer the patient. If I go to walk a patient, get him sitting on the side of the bed, stand him up and start to walk him, and that bag is on the other side of the bed, I'm going to pull it out. Turning a patient over in bed, if I trap the tubing between the mattress and my leg, I'm going to pull it out. We pull out way more catheters than your patients do because as they start to tug on it, it starts to hurt and they stop. We are responsible for this. So that's why a lot of CNAs try to hide this. Because if they were responsible for that catheter coming out, they're afraid that they're going to get lectured. I'm sorry, but if you pull the catheter out, you deserve a lecture. Let's talk about how we shouldn't be doing that and how to avoid that in the future. And yes, you will get one, and yes, you deserve it. Don't hide the catheter. Don't make the patient pay again for your error. They've already paid once. That's enough. Make sense? CNA should always be aware when a patient has a catheter so it doesn't accidentally get pulled out during routine activities. We do a lot of movement with these patients. So we're going to put it in an empty trash bag, notify the nurse right away, and let them inspect it. There are a few different types of catheters. This, and remember, everything has 2 or 3 names, so keep that in mind. This is the kind that we're most familiar with. This is the kind with the bubble on it, and it's designed to stay in. That bubble is there to keep the catheter from coming out. It's a doorstop. That's all it is. It is called an indwelling catheter or a Foley catheter because the guy that invented his name was Foley. So Foley catheter. Now, if we just need a catheter for a few seconds just to empty the bladder, but it's not going to stay in, we don't need the bubble. Bubble catheters are expensive, so we don't need that bubble. We're not going to use that catheter. We're going to use a different one. This is called a Red Robinson, a straight cath, or an intermittent cath. No bubble. Looks exactly the same, except it only has 1 port instead of 2, and no bubble on the end. Well, it doesn't need that second port because there's no bubble on the end. Okay, so this, and it's a different color so you can see right away. So straight cath, not left in. Indwelling cath or Foley, left in up to 30 days. Then we have a different type of catheter. This is called a external cath or a Texas catheter or a condom catheter. So it's got 3 different names. This is what those guys in the stadium would use. It goes on like a condom. Instead of this type of port on a long tube, that port is now right at the end. So this would attach to a leg bag. Okay, so the catheter would go on over the shaft. It would attach to some sort of a bag or collection device, and it now becomes a fully mobile type of catheter for our patients that are out and about. Now, this is mainly used for men. There are now some female external catheters, but they're not utilized very widely. All right, so when we do catheter care, we're going to clean the catheter tubing and the skin around the catheter. Doesn't matter which one you do first, nobody cares. Do the skin first and then the tubing, that's fine. Do the tubing first and then the skin, nobody cares. Just do both. Okay, so when we're cleaning the peri area, we're going to use that leaves method. You guys remember the leaves method? I'm going to hold the washcloth in a diamond shape with the free corners at the top. I'm going to wipe down the center, just like with pericare. So I need to hold her open, but I'm also going to hold that catheter out of the way. I'm going to wipe down the center, fold that over, clean one side, top to bottom, fold that over, clean the other side, top to bottom, fold that over. The crease or skin fold, top to bottom, fold it over, and the other crease. Whatever we wash, we rinse the exact same way. I'm also going to make sure you're always away from the urethra. and hold that catheter so that it's out of the way. When we're doing cleaning the catheter tubing, we're also going to hold the catheter, but in a different way. So go back one. Here, we're just kind of holding it up out of the way. But when we're cleaning the tubing, we want to hold the catheter where it exits the body, because as we put the washcloth around it and pull along the surface of the catheter, we don't want to pull on the inside of the body. So you want to hold that catheter steady as you're cleaning along the catheter surface so it doesn't pull on the inside. And we're going to, there's a balloon in there that's holding it, but if you pull too hard, you're going to pull that balloon out. They're squishy. So when we're doing this, when we're wiping the catheter, we're going to wipe away from the body, holding it next to the body, and we never go back up. So this is just like pericare, one direction. We'll clean away from the body. We have to clean about 3 to 4 inches down the catheter. I always clean the whole thing. I'm there. It doesn't take any extra time. So I just wipe the whole thing. So remember, we're going to follow the care plan, provide catheter care with soap and water to a female resident with an indwelling urinary catheter, clean the catheter tubing and perineal area only. So we'll start with our opening. Knock, knock, knock. Hi, Ms. Jones. My name is Patty. I'm here. I'm your CNA today. I'm here to do some catheter care. Is that okay? I'm going to close your curtain, wash my hands, get my supplies. I'll need a barrier because I need supplies. We're going to get water. We'll check it. They'll check it. We're going to use a privacy blanket for this to minimize exposure. We definitely need some gloves. Think about where we're at. First thing our gloves should touch is our patient. We are going to have to put a pad under the patient for this skill to keep the sheets dry. So in order to put anything under the patient, we're going to scoot them toward us, roll them up on their side, put the pad under the patient, and roll them back onto the pad. Remember, clean rolls toward me, dirty rolls away. Once we've got them all set up, we'll roll the gown up in the blanket, put the towel over the legs to minimize exposure, and then we can start cleaning. We'll wring out our washcloth, soap 5 corners, and just like we did with pericare, hold the catheter in place, and we're going to clean 5 strokes, top to bottom. Whatever we wash, we rinse. Whatever we rinse, we dry. And then we'll clean the tubing. We're going to wring out our washcloths really well. We're going to soap 4 corners this time. And then we're going to wipe away from the body. 4 strokes. Whatever we wash, we rinse. Whatever we rinse, we dry. Then we'll unroll the privacy blanket to cover her back up. We're going to remove that chucks, scoot and roll. And then we're going to take care of all of our used supplies before we take our gloves off. After we've taken care of our supplies, stored our basin, we'll take those gloves off, and then we can remove that privacy blanket and do our closing. Pretty easy, right? So let me pass this around so you guys can see how the catheter works. You can feel free if you want. It's water. I know it's discolored. It's because of the catheter. But you can just plug it in and put the water in to inflate the bubble, or you can take the water out. So you guys can kind of play around with it. I find that just being able to handle the catheter, to know how it's used, really helps reduce the amount of anxiety that you guys have about working with catheters. It takes a lot of that fear away. It's just a flexible straw attached to a bag. That's all it is. Before I show you this video, though, I'm going to go into the next skill because they really go together. Catheter care and emptying the drainage bag are going to be done at the same time in a clinical setting. For the test, they're 2 separate skills. But I want to show you the videos back to back because in a clinical setting, they really do go together. And then after you see those 2 videos, the rest of the class will be yours for practice. Okay, so we're really close to being done. So let's talk about drainage bag. This is going to be on page 164. This is our very last skill. If you look down the side, you can see all of the steps involved, all of the principles involved. They're all spelled out for us here. This skill should take somebody with your level of experience 9 minutes or less to do. The mannequin will be the patient for this, not a live person, and they'll be in bed. This is a charting skill. We're going to measure the urine that comes out of the bag, and then we have to document that at the end. It's okay. Right, so it's deflated when you put it in, when the nurse puts it in. Once it's in the patient, we put the water in the bubble to inflate it, and that keeps it in place. All right, so our care plan is at the top, page 165. It tells us to empty the resident's urinary drainage bag into a graduate container and measure and record the output in mLs or cc's on the intake and output form. So this is the intake and output form here. You can see a small version of it. If you go to page 169 in your book, you've got a bigger version of it. I want to point out, though, that there is a section for intake and there is a section for output. What is urine, intake or output? I hope so, because if you put urine up here in intake, you are legally declaring that this person drank urine. Absolutely. So for this skill, it's not just enough to document, it's enough to, you have to document in the right place.
Why would you put urine in here? I'm just like the texture.
Yeah. All right. So both types of bags that we've discussed, a bedside bag and a leg bag, both of them attach to a catheter. They both attach to the catheter. So it doesn't matter whether you're emptying a bedside bag or if you're emptying a leg bag, they both are attached to the same system. So bedside bags are usually a T valve. So you can see that on the bag that I'm passing around. It's a T valve. We're going to talk about that in a second. And leg bags have a screw valve. So you would unscrew to allow the urine out of the bag, where this is a T valve. So you have to push the valve to the side to open it. When we empty the bag, remember the bag can't touch the floor. It's on a non-moving part of the bed, but we're going to empty it right here. We don't want to lift that bag above the level of the patient's hips. So we're going to put the chucks on the floor, and then we're going to put our graduate container on the chucks. We're going to empty the urine into the graduate container. When we do that, we don't want to touch anything on that bag that could contaminate that area. So we're opening that valve. Remember I said there's 3 places that pathogens can get in, and that valve is one of them. When you open that T valve on the bag, you can't let the end of that port touch anything. It can't touch the cup. It can't touch the floor. It can't touch the chucks, and it can't touch the bed. It can't even touch your gloves. The end of that port touches nothing, because that's where pathogens are going to get in. Okay? So you've got a chucks on the floor, you've got a cup on the chucks, you've got your bag there. We're going to open this T valve and empty the contents into the cup without that T valve touching anything in that environment. So this is a T valve. This is what it looks like. And you can look at it on the bag that's being passed around. We can pass it back around so you can look at the bag. This, see how it's like a T? That's why it's called a T valve. You would push this end all the way through to open it, and then you're going to push it back the other way to close it. That's how a T valve works. It should always be closed unless it's actively being emptied. We don't want an open doorway for pathogens to get in. So it has to be closed unless we're actively emptying it. Remember that the tip here cannot touch anything. Anything. So we empty the urine into our cup, and then we have to measure this urine. So when we're measuring the urine, we're going to use the cc side, not the ounces side. We don't use ounces in healthcare. We're going to use this side. So it's going to be measured on a barrier, on a flat surface, and you need to be down at eye level to read it. So this is what the graduate container looks like. And you have one of these in your practice kits. If you purchase the practice kit, you have one of these. You also have a bag, a drainage bag in your kits. So if you empty the urine into this cup, we're going to measure it on a barrier, on a flat surface, and then I've got to get down at eye level. I can't hold it up like this. You don't want to hold urine up. Ick. So on a barrier, on a flat surface at eye level. And we're going to use the cc side, not the ounces side. We are going to round to the nearest line. So when you're looking at the cup, you want to round to the nearest line. They're going to be measured in 50s. So there's a line for 250 and a line for 300. There's a little line in between that has no numbers. That would be 275, right? Between 250 and 300 is 275. Round to the nearest line. And then at the end of the skill, this is what we're going to put on our output section of our intake and output form. The time, military time is best. Bless you. Bless you. The type of output, which in this case is urine. The amount, however much you measured, and then your initials. Of course, we have to wash our hands after documenting. So for this skill, we'll read our care plan. We'll do our opening. We're going to place a barrier on the floor. Get the rest of our supplies. We definitely need gloves because there's body fluids. We're going to empty the bag into the container, not letting that port touch anything. Anything. You can tip the bag to make it a little bit easier, but don't raise the bag above the level of the hips. Guys, the number one error that's made on this for the test, and to me, this is just crazy. I don't know why people think about doing this. But the number one testing error for this particular skill is people separate the bag from the catheter and take the whole bag over to the toilet to empty it into the toilet. No, we don't separate those two pieces, number one. Number two, if you're emptying it into the toilet, you can't measure it because the markings on the bag don't count. That's not an accurate measurement. Once you're going to open your T-valve, empty into the cup, the measuring cup, close the T-valve before you put it back in to its house. Don't let that end of the port touch anything. We'll wrap that container of urine up in the chucks. Remember, we don't carry an open container of human waste anywhere. We're going to take it over to the toilet. We're going to set it down on the lid of the toilet. And we're going to get down at eye level to read it, round to the nearest line. Then we'll pour our contents into the toilet. We're going to rinse, dry, and store our graduate container. And then we can remove our gloves. We'll do our closing, document on the output section, and then wash our hands again. Good? Questions on these two skills? No, and we used to wipe it off with alcohol pads. But what we found over studies is that the alcohol is a drying agent, and it actually dried out this plastic polymer material and caused micro cracks to form. And that allowed bacteria to be harbored in those areas. So this is one of those situations where we think we're doing a good job, and it actually ends up not being good. So that's why we constantly do studies and investigations and, different types of experiments to see. So we don't clean it off. The emphasis now is just don't let that port touch anything. But that's why we change it every 7 days, because it would take a long time for a bacteria to get from the bag all the way up into the patient. So if we remove that bag every 7 days and put a new one there, it reduces the chance of infection with the patient. Good? That's a great question. Any other questions?
I don't have a question, but when I had my son, I had to have a catheter because I had an emergency C-section, and my CNA didn't. I don't remember exactly what it was, but I had got there at like 3 o'clock for an appointment, and then they realized I had to have an emergency C-section, so got an epidural and got a catheter. But then my doctor, it took a couple hours for my doctor to get to me. She came in my room and there was urine on the floor. And I had already had a catheter for like 3 hours and I was numb. Couldn't move my lower half.
Yeah.
And I actually ended up getting an infection. I was in the hospital with my son for 4 days because I had a C-section. But they took my catheter out on the second day, and I was there 5 days because on the second day morning that I was there, they took my catheter out and I wasn't able to have any urine output for like 2 days, and I was on steroids and stuff.
Hmm.
I ended up having an infection, but they didn't know until they took the catheter out and I wasn't able to have any urine output.
Yeah, and that, unfortunately, it's a risk when we put a catheter in.
Yeah, I mean, I still like long-term effects. I get like kidney infections really easy.
Yeah.
Because it did weaken my kidneys. I ended up having to have like steroids and stuff after I left the hospital for my kidneys, because it was actually I had a catheter for 2 days. So.
Yeah, and just that quick caused major, most likely lifelong implications.
Yeah, I have really weak kidneys now. I mean, I had my son really young, too, so my body was already
You stressed over that, right? Right.
So, I mean, the infection kind of just weakened my kidneys.
Sure, absolutely. So this is why catheters really are kind of a last resort, because we never know. It's like a Pandora's box. Like, 80% of the time, there's no problem. You put a catheter in, you take it out, no issues at all. But 20% of the time, there's issues.
It just wasn't attached all the way, I believe.
Yeah.
My bag wasn't attached to the actual catheter hose all the way, but I mean, it was unattached for about 3 hours. There was quite a bit of
And allowed
urine on the floor.
pathogens to get in.
And
Yep.
It was close to the floor, like just knowing how close I was to the floor with another patient, like, thinking about it.
Yeah.
Yeah, there's a lot. There's a lot of stuff being trapped in and out. So
Absolutely. Absolutely. Yep. So what we do really matters. It really matters. All right, so let me show you these 2 videos, and then I'll finish up for today. We'll talk about Jake is going to be passing out the review sheets for today. We'll talk about next steps. We'll talk about next class, and then I'll sign off of online so that you guys can practice. Okay. Catheter care, please. Good afternoon, Mrs. Jones. My name is Patty. I'm your CNA today. How are you? Wonderful. I'd like to perform catheter care. Is that okay? Okay, I'm going to close your curtain for privacy, wash my hands, get my supplies, and I'll be right back. Now that I have clean hands, I can get my clean supplies. We're going to place a barrier on the table with the absorbent side facing up. This gives us a clean area for our clean supplies. And for this skill, we're going to need 1 underpad. We're going to need a towel, 4 washcloths, 1, 2,
3, 4. We're going to need a privacy blanket. We'll bring this over to the patient area. And I'm going to need a basin and soap. And a set of gloves. All right, Miss Jones, I'm just going to fill your basin. I'll be right back. To fill the basin, I'm going to use a paper towel to turn the faucet on because my hands are clean. I'll use my wrist to feel the water temperature. It should feel warm, not hot, not cold, just warm. And we'll fill the basin about 1/4 of the way full. Mrs. Jones, would you like to check the water temperature? It's good? Wonderful. Okay. I'm going to place this privacy blanket over you, and this is going to help keep you warm and provide privacy as we do this skill. So I'll lay the privacy blanket over the sheet without snapping it or shaking it, and then pull the sheet down to about your waist. I'll put the washcloths in the basin. That way they get warm. And I'm going to prepare the underpad to go under the patient. I'll open it up. I'm going to hold it up lengthwise with the absorbent side facing me, and I'll roll it all the way to the end. Now I can put my gloves on. Okay, Miss Jones, we're going to place an underpad under you to keep your sheets dry while we do this skill. So I'm going to place an underpad on the bed. And in just a moment, I'm going to ask you to scoot toward me. I'm going to roll you on your side, and then we'll spread that underpad out. So on the count of 3, go ahead and scoot toward me. 1, 2, 3. Thank you. And now I'm going to roll you on your side. 1, 2, 3. And as I roll the patient, I want to be careful not to put any stress on this catheter or the tubing. You don't want it pulling tight. So I'm going to unroll the chucks underneath the patient and tuck it under her hip. Miss Jones, come on back. And scoot to the middle of the bed, please. Okay, Miss Jones, we're going to repeat the process. Go ahead and scoot toward me. And we're going to roll you onto your left side. 1, 2, 3. And I'll smooth that chucks out underneath the patient. Come on back onto your back. And then scoot to the middle. Now we can begin the cleaning. Ms. Jones, I'm going to expose you. I'll make this as brief as possible, but please let me know if you're uncomfortable in any way. I'm going to roll the privacy blanket, making sure that I get the gown inside the blanket as I roll it. But I don't want to grab that catheter as I'm rolling the blanket. So you want to be very gentle with this process. This is going to expose the peri area. And then I'll place a towel over the upper thighs and make sure that the catheter tubing is on the towel. This is to help minimize exposure, increase comfort, and gives a place to put the catheter while we're cleaning it. Now I'm ready to start cleaning. I'm going to take my first washcloth, wring it out, and I'm going to soap 5 corners. 1, 2, 3, 4, 5. I'm going to hold the catheter out of the way, retract her labia, and then wipe down the center top to bottom, and then move away and fold that leaf. The second leaf will wash the outside of the labia, top to bottom. We'll fold that leaf over. This is going in one direction only, top to bottom. This third leaf is going to wash the other side of the labia, top to bottom. We'll fold that over. The fourth leaf will wash the skin fold between the leg and the groin, top to bottom. We'll fold that over. The last leaf will wash the skin fold on this side, top to bottom. Now we'll set that aside on the barrier. And whatever we wash, we rinse. So we're going to wring that washcloth out really well. Hold it using the leaves method. I'll hold the catheter out of the way and open the labia and rinse down the center one direction, top to bottom. We'll fold that over. We'll rinse the outside of the labia, top to bottom, fold that over. The other outside of the labia, top to bottom, fold that over. This is going to rinse the skin fold. Fold that over, rinse the skin fold. We'll set that aside. Now we're going to clean the tubing. So I'll get washcloth number 3, wring it out really well, hold it using the leaves method. And I'm going to soak 4 leaves. 1, 2, 3, 4. I'm going to hold the catheter where it exits the body so it doesn't pull on the inside. Wrap the washcloth around the catheter and wipe away from the body. We're going to fold that over and repeat 3 times. Hold the catheter, wipe the washcloth around, and move away from the body. 2, 3, changing the leaf for each stroke, and 4. We'll set this aside. Whatever we wash, we rinse. I'm going to wring the rinsing washcloth out thoroughly, hold it in the diamond shape in my hands, hold the catheter where it exits the body, wipe the washcloth around, and rinse going down the catheter. We'll fold that leaf, rinse 2, fold that leaf, rinse 3, fold that leaf, and rinse 4. We'll set that aside. Whatever we rinse, we dry. So we'll dry the peri area top to bottom and the catheter tubing. We can remove the towel, set it on the table, and we're going to unroll the privacy blanket, trying to be careful not to touch that gown with your soiled gloves, and we'll cover the patient up. Mrs. Jones, can I get you to scoot toward me, and I'm going to remove the pad that's under you. Go ahead and scoot toward me, and on the count of 3, you're going to roll up. 1, 2, 3. I will roll the soiled chucks toward the patient and tuck it underneath her hip. Come on back, Miss Jones. When I'm moving Mrs. Jones, because my gloves are soiled, I'm only touching the outside of the privacy blanket. Mrs. Jones, scoot to the middle of the bed, please. And now we can remove your chucks. If you can scoot toward me, again, my soiled gloves are only going to touch the outside of the blanket. And then you're going to roll up on your side, 1, 2, 3. And I'll remove that chucks from under the patient. Come on back onto your back. And then if you can scoot to the middle. Thank you. I'm going to go dispose of this. Okay, Mrs. Jones, you're covered. You're safely in the middle of the bed. I'm going to go dispose of your linens and clean your basin. I'll be right back. These items will go in dirty linen. We're going to clean this basin the way we clean all basins. I'll bring the basin to the sink and we'll dispose of the water in the sink. Rinse the basin and then dispose of the rinse water into the sink as well. I'm going to set that down, disinfect it per facility policy, and then pick it up with a paper towel. I'm going to get a clean paper towel to dry the inside. I'm going to get a clean paper towel to dry the outside. And then one more for the drawer. On the way, we'll pick up the soap, place it in the basin, use the paper towel to open the middle drawer, pick up the lotion and put it in the basin, and then store the basin in the drawer. We'll close it with a paper towel and then throw those paper towels away. Now we can dispose of the barrier. This will go in the garbage, and I can remove my gloves. Okay, Ms. Jones, I'm going to remove your privacy blanket now. I want to check your tubing real quick just to make sure that it's not kinked and you're not lying on it. So it looks good. It's not near the floor. So I'll pull the sheet up over the privacy blanket. This ensures that you're always covered. And I'll remove the blanket as I do so. Want to make sure that the blanket is rolled into a ball so trailing edges don't contaminate other surfaces. We'll make sure that the sheet looks good. All right, Ms. Jones, just let me go dispose of this in dirty linen. I'll be right back. We'll adjust the sheet on this side. There you go. Is there anything else I can get for you while I'm here? Are you comfortable? Would you like a magazine? Your bed is in the low position. Your environment is clean. Here's your call light. If you need anything at all, go ahead and press the red button. We'll be happy to come help. I'm going to open your curtain and return your overbed table to storage. Now I'll go wash my hands. After washing my hands, I'll review the care plan, make any corrections, and tell the evaluator my skill is done. Good evening, Mrs. Jones. How are you today? Fantastic. I need to empty your urinary drainage bag. Is that okay? I'm going to close your curtain for privacy, wash my hands, get my supplies, and I'll be right back. After washing my hands, I'll get my supplies. We're going to start with the chucks. This is going to go on the floor under the bag. We're going to place the barrier on the floor directly under the urinary drainage bag. So we'll unfold it and we'll place it under the bag with the absorbent side facing up. I'm going to go get a set of gloves. And we're going to get the graduate container out of the drawer. You need to make sure that you put your gloves on before you get the graduate container. We're going to place the container on the barrier directly underneath the bag. We use the emptying port to empty the bag. This is a T-valve. We slide it to the side to open the valve, and then we're going to empty the urine into the graduate container without letting that port touch anything. Once the bag is empty, we'll close the port and place it back in its little house. All right, Ms. Jones, I just want to check to make sure the tubing is coiled on the bed and you're not lying on it, and that it's not coiled near the floor either, where it could become a tripping hazard. Now, I can wrap the chucks around my graduate container for safe and secure transport to the bathroom. We're going to set it down on the lid of the bedside commode and unwrap it, turning the cup around so that we can read the amount of urine that's in the cup. We need to be at eye level. It needs to be on a flat surface and on a barrier. I'm going to throw the chucks away, open the lid and the seat, and dispose of the urine into the bedside commode. I'll rinse the cup and dispose of the rinse water into the bedside commode as well. We'll close that, set the graduate container down in the sink, and disinfect it per facility policy. I'll pick it up with a paper towel, dry the inside with a paper towel, throw that away, dry the outside with a paper towel, throw that away, and one more for the drawer. Okay, Miss Jones, I'm just going to return this to storage using a paper towel to open the drawer. And closing the drawer, we'll throw those paper towels away, and then I can remove my gloves. You take a peek at your tubing just one last time. Everything looks good. Are you comfortable, Mrs. Jones? Is there anything else I can get for you while I'm here? No? Would you like a magazine before I go? Your bed is in a low position. Your environment is clean. I'm going to open the curtain. Here's your call light. If you need anything at all, just press that red button. We'll be happy to come back and assist you. Thank you very much. I'm going to go wash my hands. After washing my hands, we'll document the amount of output on the documentation sheet provided by the evaluator. We're going to document the time of output, the type of output, which is urine, the amount of output in cc's, and my initials. We want to make sure that we're documenting in the output section. After documenting, I'll wash my hands one final time. After washing my hands a final time, I'll review the care plan, make any corrections, and then tell the evaluator my skill is done. Do you have to use military time on documentation? And the answer is no. You can use regular time, but you have to put the AM and PM if you're using regular time. You should know how to use military time, though, because you are going to use that in most facilities. Healthcare runs 24 hours a day. I do have a whole lesson in your book on military time that will kind of walk you through how to do it. I have a whole lesson going into the online course next week. I'll be adding that lesson in there with a lot of interactive examples of military time.
I've been wanting to ask this for a minute. For the skills test, you have to like talk how you talk, like be so specific when you're doing this.
Okay, so the answer is yes and no. You have to talk to the patient. They need to know exactly what you're doing on their body. So you have to explain what you're doing. You don't have to do it exactly the way I do. You don't have to say the same words, but you do have to talk to the patient. Imagine how awkward it would be if you were in a strange place, you knew nobody. You're there all by yourself. You're scared, and somebody is coming in and undressing you. How frightening would that be? Pretty frightening. So we'd want to let them know, okay, I'm going to get you undressed, but I'm only going to expose exactly what I need to. Let me know if you get uncomfortable. There's a big difference in the way that patient's going to respond than somebody that's going to respond, if you just walk in quiet and start undressing them. So I have a lesson in the online course about this too. It's called Do I Have to Talk It Out? And it explains that. So the online course is going to have some lessons that we did not cover in here. If you haven't gone through the online course, I would definitely make that, work that into your time schedule.
So with the online course, you said like when we pay for everything, we pay for that. Do we have a certain amount of time we're allowed to use that? Or
A year.
A year.
Mhm.
Okay, so it's not like once class is over, we have like.
You have a year. Yeah, a year from the day that class started.
Okay, awesome.
Yeah. So that's a really good way to review for the state while you're waiting to test. That online course is very, very helpful.
So it's only us, like the people that sign up for the course?
The online course is being used right now. I think I have 1,200 people on there right now. It's being used by schools all over the country. There's a lot of schools that use my online course as their classroom. So they don't come to a class like this. They do everything online, and then they go in to practice the skills. So then there's individuals that just pay for the online. That's all. That they don't come to class. They don't come in here. They just purchase the online. You guys get the online as part of your tuition to here. But yeah, that online course has over 130 lessons in it. Very, very robust. But it's interactive. It makes it a little more fun. By next year, I'm hoping, keep my fingers crossed, by next year, my classes won't have the yellow textbook anymore. I'm not going to be using the Hartman textbook any longer next year. All of the lessons that are in that textbook will actually be online as part of the online course that they'll have to complete as part of their homework. It makes it the lessons are shorter. It's a little more interactive. And I mean, textbook reading is just so yesterday. So it makes it a little bit easier. So, but all of that is available to you. So Jacob passed out your review sheets. You have one final chapter of homework tonight, chapter 10. It's all on employability and stress management. It's not a hard chapter. It's very short. But on Wednesday, you need to bring that yellow book back to me. You have to turn that one in. So if you fell behind in your homework reading, you're going to have a lot of catch up to do before Wednesday because I need that yellow book back. Okay. Graduation day. Nothing special going on for graduation day. I do need you to be in your t-shirts though, because we do take a class photo. I will post it on our social media. I don't tag you. You have to go find it and tag yourself or share it. But I will post it on our Facebook page for you. Employers often reach out to students when they see that, with job opportunities, application invitations. So you definitely want to be in that photo. Graduation, there's nothing special for it. If you guys want to bring in cookies or cupcakes to celebrate, you're more than welcome to. It's not that, you're not going to be on a stage or anything. It's in here. But I will give you some final information, how to renew your certification, how to do continuing education, how to find a job in healthcare, some application tips to make sure that your application gets routed to the right place rather than being discarded. If you're trying to apply to a hospital, over half of the applications that are made to hospitals don't even make it to human resources. They get discarded immediately, over half. So in order for you to get your application to pass through those filters, you've got to know a few things. So we're going to talk about that in class on Wednesday as well. You'll also have some practice time in class on Wednesday. Okay, so that's the plan for next class. Just remember, you have to be in your t-shirt and bring your yellow book back on Tuesday for graduation. All right, so I'm going to go ahead and sign off of online. Thank you guys so much for joining us. We really appreciate it. We'll see you tomorrow for the game show at 11 a.m. and Wednesday for graduation. Make sure you tune in for graduation. I'll give you a really cool way of answering. Tell me a little bit about yourself that's specific to you. So we'll see you then. Until next time, happy caregiving. Bye.